Hello everyone. A frequently encountered question in clinical practice is how long will IV fluid remain in the intravascular system? In the previous lecture, we learned about half-life of IV fluid in a normal person. Today we'll explore the various pathological factors influencing the duration of IV fluid within the intravascular compartment. Many healthcare professionals assume that infused fluid rapidly shifts into the interstitium due to capillary permeability. My objective is to provide a comprehensive overview of additional factors influencing fluid dynamics in a patient so that you can have a better understanding of these. From the previous lecture, we understood that the fluid leakage out of capillary is not the only factor that governs the time that fluid will remain inside the intravascular compartment. We have to consider both stressed and unstressed compartment, lymphatic drainage, and state of your interstitium along with the urine output. So let's understand each of these moments and the factors that govern them. You should then be able to apply this knowledge to your patient. The following discussion will apply to any IV fluids. Let's talk about the vascular compartment first. The blood in the arterial compartment is the stressed volume, and this is the compartment that generates your perfusion pressure. The blood in the venous compartment has both stressed and unstressed portion. Stressed venous compartment governs venous return, while the unstressed venous compartment stores the volume. So 30% of your blood is in the arteries, that is your stressed compartment, and your 70% of your blood volume is in the venous system. The veins are interesting because in the completely collapsed state, there is no pressure on and there is a minimal volume. And as you add volume to the venous system, the pressure does not change. So you can put in a lot of volume in the veins without increasing your pressures. And this is one of the reasons why volume status does not correlate strongly with venous pressures. However, once a certain volume is reached, the walls of the vein are completely stretched, and after this, as you increase your volume, your pressure will rise steadily. So when your patient has significant hemorrhage, say for example 10 to 15% of the circulatory volume, you do not affect much of your cardiac output because as you are losing blood, you are developing venoconstriction, which is diverting the blood from your unstressed compartment to your stressed compartment. When you give large amount of norepinephrine to these patients, causing maximal venoconstriction, you can shift up to 15 to 20 ml per kg of blood volume, which is about 1.5 liters in adult, from the unstressed compartment to stressed compartment, thereby maintaining the pressure. The other two factors that can help maintain the perfusion is decreased capillary filtration due to hypotension and increased lymphatic activity during episodes of hemorrhage, which help in maintaining the stressed volume. So venoconstriction can divert blood from unstressed compartment to stressed compartment by two ways. The first way is to change its elastance. That means increase the stiffness of the venous vessels. And that would be seen by a steeper slope of the pressure volume curve in the figure. However, when you give high dose of epinephrine or sympatholytics, they seem to have no effect on venous elastance. The second way is change in venous capacitance, that is converting your unstressed blood volume to stressed blood volume. And this can be observed by looking at the left shift of the pressure volume relation. So as your venous capacitance decreases, you have more stressed volume and less unstressed volume. And we have observed that administration of sympathomimetics like epinephrine or sympatholytic will significantly change the capacitance of the venous system. So in venoconstriction, change in venous capacitance gives rise to transfer of more blood from unstressed to stressed compartment than changes in venous elastance. So when you give fluid in your hemorrhagic patient, higher amount of fluid that you give will remain intravascular. And this happens because as you give them fluids, it's going to reduce the sympathetic nervous system stimulation, therefore releasing these veins from contraction. So diverting some blood back from your stressed to unstressed compartment. Let's talk about the second part, which is your net filtration from the capillaries. And this takes us back to your modified Starling equation. So your net filtration depends upon permeability, hydrostatic pressure gradient, and Stabermann's constant. Any process that increases the net filtration will reduce half-life of your IV fluid and vice versa. Please watch my earlier video on Starling equation to have understanding of this equation. Most important component is your hydrostatic pressure gradient. Decreased hydrostatic pressure gradient will increase half-life of your fluids. To look at it visually, if your capillary pressure drops, your net hydrostatic pressure gradient will drop as well, and that will decrease the filtration rate. So fluid will remain inside intravascular compartment longer if hydrostatic pressure in the capillary is low, which is seen in any hypotension. Hydrostatic pressure gradient depends upon severity of hypotension. Remember, the hypotension not only reduces your capillary filtration, it also reduces your urine production. Both of them increase the half-life of your fluids. So IV fluid will remain much longer intravascularly when you give these to hypotensive patients. Next is the degree of venoconstriction or venodilation. Since most of your blood is present in your unstressed compartment, the perfusion pressures will drop during venodilation as seen in patient during anesthesia or use of venodilators. Next is the amount of IV fluids transfused. As you give more volume of fluid, the half-life of fluids decreases. And this happens because as you keep on giving fluid boluses, your perfusion pressures improve, thus increasing your hydrostatic pressure gradient and increasing net filtration. So one of the things to remember is as you keep on giving more fluids, the half-life of the fluids slowly decreases. In these situations, when you give IV fluid to your hypotensive patient, it will certainly stay intravascular for a much longer period, but as the perfusion pressure increases, the increased hydrostatic pressure gradient will result in increased net filtration and subsequently decreasing the half-life of your IV fluids. So how fluids move out of intravascular compartment depends upon how hydrostatic pressure gradient changes with your IV fluids. Lastly, but the most importantly, is your interstitial pressure. In the previous lecture, we understood that the inflammation results in degradation of your alpha-2 beta-1 integrins, and this results in your glycosaminoglycan swelling and lowering of your interstitial pressure. And remember that your hydrostatic pressure gradient is your capillary pressure minus your interstitial pressures. So if your interstitial pressures are much more negative, your hydrostatic pressure gradient increases by a lot. If your glycosaminoglycans swell, there is more negative interstitial pressure. Therefore, your net hydrostatic pressure gradient increases by a lot, and this would tend to decrease the half-life of your IV fluids. So fluids will remain inside the intravascular compartment shorter when glycosaminoglycans are swollen, that is seen in inflammatory states. IV fluids will remain inside intravascular compartment for a shorter period if your hydraulic permeability increases or your Staverman's constant decreases. Hydraulic permeability depends upon the tone of your capillary sphincter and the type of capillary bed, while your Staverman's constant depends upon injury to your glycocalyx and degree of inflammation. To know more about Staverman's constant, please review my earlier lecture on Starling equation. Next is the rate of lymphatic return. So fluids will remain inside intravascular compartment for shorter duration if your rate of lymphatic flow decreases. That means the return is much lower, and this depends upon your interstitial pressures, lymphatic contractility, and other mechanisms involved in your lymph movement. We'll talk about lymphatics in our other lecture so that we can understand the nuances and understand all these factors individually. Next is the rate of urine formation. So fluid will also remain intravascular compartment for shorter duration if your rate of urine production increases. And this will depend upon renal perfusion, autoregulation, glomerulotubular feedback, RAS and SNS activity, diuretics, etc. Lastly, the rate of absorption in the gags is very important. And as we learned earlier, that if there is any damage to glycosaminoglycans from inflammation, the interstitial pressure becomes more negative and it starts absorbing water. A lot of this water is your structural water. So the problem with the swelling of glycosaminoglycan is that the fluid that enters the space is very slow to get released. Sometimes this space is called third space. We'll talk about third space in some other lecture. There are a few other factors that can affect the half-life of your IV fluids. One of them is your RBC count, and you can see as your red blood cell count increases, your net filtration decreases. If your intracellular volume is larger, the net capillary filtration rate is much slower. And this is believed because large intracellular volume can sometimes compress the interstitial meshwork, thereby promoting a relatively greater rise in hydrostatic pressure, thereby decreasing the net filtration from capillaries. The body fluid compartment size also affect your half-life of fluids. It was interesting to note that the ratio of intracellular volume to your extracellular volume ratio, which is usually described as 2:1, changes with amount of fluid intake. If a subject takes high amount of fluid on a daily basis, the ratio of ICV to ECV can be as low as 1:1. So to summarize, how long does crystalloid remain intravascular depends upon many conditions. First is your volume status and hypotension, and that depends upon the degree of vasodilation and venodilation. It also depends upon the leakiness of capillaries, which depends upon state of glycocalyx, inflammation, stress, etc. It also depends upon the interstitial compliance and interstitial pressures, which depends upon the condition of your glycosaminoglycans. Lymphatic function and amount of volume that is infused is also important in determining half-life of fluids. Lastly, the amount of urine output. This is a comprehensive list of factors that affect half-life of your IV fluids. Some of these will increase the half-life while others will decrease it. Take a moment and go through this whole list. We'll talk about individual clinical conditions and how to use IV fluid in them in our subsequent lectures. So once you have mastered these dynamic factors in your patient, you can use this knowledge to manage IV fluids more effectively. We'll discuss about individual clinical condition in our subsequent lecture so that you can have a better idea how to use this knowledge and apply it to your patient. These are the references. Thank you.